Welcome, everyone. I'm excited to welcome you to this episode of the Sunflower Podcast, a podcast exploring all aspects of children's palliative care around the world. Sunflower Podcast is bringing curiosity, humor, and reflection to the world of palliative care. We're exploring the joys and challenges of working in this incredible field, including topics related to education, advocacy, self-care, service provision, and leadership from around the world. My name is Rachel Neufeld, and I'm thrilled to be here as a guest host for this podcast. I'm a pediatric palliative care nurse practitioner in Vancouver, Canada, working for Canuck Place Children's Hospice. I had the pleasure of sitting down with Dr. Hal Sidon, medical director at Canuck Place Children's Hospice in Vancouver, Canada. We talked about his role in pediatric palliative care research and some of the interesting things he has found. Hello, Hal.
Hi, Rachel.
I'm wondering if you could introduce yourself and your role, please.
Yes, I'm Dr. Hal Sidon. I'm the medical director of Canuck Place Children's Hospice in Vancouver, Canada, and medical director and division head of palliative medicine at BC Children's Hospital and BC Women's, also in Vancouver.
Fantastic. Thanks for sitting down with me for a couple minutes here.
Pleasure.
I was hoping you could tell me a little bit about your work with the Research Institute in the context of pediatric palliative care.
Yeah, so I've been a member of the BC Children's Hospital Research Institute actually since 2003. And I had the good fortune to start doing research with a number of luminaries in pediatric palliative care, including Betty Davies and Rose Steele, who were groundbreaking nurse researchers in the field and really some of the founders of research in this area. And we began a project together as a new emerging team of research, really following kids with non-cancer diseases. And that was the first of our many, many big projects. And since then, I've continued to have a relatively active research group that sits at the Institute. And my clinical work is really been focused here at Canuck Place. And I've always said that the heart of our research was at Canuck Place, and the kind of the hands and brains, all the back office stuff sits at the Institute, and that's how we've combined it.
So I feel like research in palliative care in general, and then also in pediatrics, can be difficult to do. How do you find running research studies in pediatric palliative care, and what are some of the barriers that you encounter?
Well, I'd say that the barriers, thanks for asking. I'd say that the barriers, first of all, I'd say all clinical research is difficult to do. It's much easier, a little more expensive to involve, animal models or computer data sets or whatever. So when you start trying to work with people, it automatically increases the difficulty, whatever the field. I would say that in 2003, 4, 5, we were cautioned, we ignored the caution, but we were cautioned not to use the term pediatric and palliative in our terms. People were scared of it. We're way, way past that now. So I think that the difficulty now is that we're dealing with families who are very, very busy. They're very intensely involved with their children's highly complicated health lives. And regardless of whether it's a cancer diagnosis or one of the non-cancer diagnoses, we really have to work with them to make sure that they can find time and space to work with us on research. One of the things that has helped us really a lot in the last few years is to bring on parent partners who are active researchers in my group, two individuals who both are parents of children with high degrees of complexity, but are in and of themselves research assistants for us. And they are a fantastic bridge to help us not just liaise with families, but to understand families' needs and how to best engage them in research. So that's been a big game changer for us.
Yeah, and that's going to have some personal context then too.
Yeah.
Because one of my questions was, how do you find families who want to participate?
And even my two fantastic parent researchers find it hard. They recognize the challenges of how they don't have some magic. They are very connected to families, but these families are very busy. So it's not unusual for us to have 50 families say they're interested in the study, 10 to RSVP, they're going to be there, and the day of the survey, focus group, or whatever, there's 4 of them. That's a pretty common event. And we're doing everything we can. And families, and Lisa Kim has written this up, it's now been a published paper of what motivates families. Families are actually very motivated to be in research. They see that it's a benefit potentially to their child or children like their child, and they feel strongly motivated primarily because of wanting to give back and interested in the results, and they're interested in what we're doing. So it's really a matter of time and energy, of how to design studies that are minimal time and energy for families.
Yeah. because they're the ones that are taking care of the children. They're
Yes.
monitoring for the symptoms.
Right.
They're watching for
Exactly.
side effects.
Exactly.
And they have to be quite diligent in that record keeping.
Yeah, and we try to make sure that the record keeping is simple and doable. We cut way back on the number of instruments we use. We try to just use a couple of key questions that point. We're actually moving very strongly. I'm working with one of my colleagues, Tim Oberlander, on a project called Living Lab at Home to use things like wearable technology and things that are easy to collect, like a child's saliva and looking for molecules in that. So we're trying to even take it away from parents having to answer questionnaires and
Right.
trying to use real-time observation of children. I would also say that our research in our group has expanded. It's not just clinical research of this child and what are his or her symptoms. We also have a large number of studies that we've done around how are families coping, how are siblings doing. So a lot of biopsychosocial or psychosocial research has gone on, primarily with parents, although some with youth and children. And then we're also doing big data set research. So we're looking at population data. Who are the children? How do they access services? Are services available everywhere? How are they utilizing those services and resources? Because this is a field that didn't exist in 1990, so we're starting from scratch across every phase of like inquiry.
Right. And I can imagine that some of that is going to then inform how programming expands.
Absolutely.
Because you know where they're accessing care, where they're not, where the
Right.
gaps are,
Right.
where do we need to fill in.
Right. I mean, one of the projects that we published last December, and Elisa Castro Noriega, who's the statistician health researcher for Canuck Place, was lead author on this, was the number of kids in BC who are potentially going to be users of pediatric palliative care. We did not have a denominator.
Right.
And all of our assumptions were based on pretty mediocre data from other jurisdictions, other places, and even their data wasn't that great. And we've benefited from people like Lorna Fraser in the UK who've done great work and worked with Lorna and used her techniques and applied them in BC to a massive data set. And that's finally given us some very good numbers that we can then take to the hospice, we can take to government, we can take to the Ministry of Health and say these are numbers you can rely on about the number of kids and where they live and how far are they from Vancouver and all the other kind of questions you have.
I know of the one particular study that I have now used quite regularly as a reference.
Right.
So can you tell me a little bit about your PIUO study?
The PIUO study.
Yeah, PIUO.
PIUO. So PIUO stands for pain and irritability of unknown origin. And I'll give you the etiology of the beginnings of the study. Around 2010, Tim Oberlander and I and Bruce Carlton, who's also in the Institute, wanted to do a drug study of children, nonverbal kids with neurologic conditions who had pain and they weren't able to tell us about the pain. So we thought, well, we wanted to ask questions about the medications that were being used and which one might be helpful and so forth. So we recruited through a group of community pediatricians, children who fit this group of categories. And in the letters to these pediatricians, we said, we want you to have worked up the child for all the potential causes of pain. And what we're left with is this kind of brain-based pain. So in other words, make sure they don't have a dental abscess or raging, ongoing UTIs or whatever else was. And of the 12 kids we recruited, not a single one had a complete workup done. And what we also discovered was that the average child in that study had seen 7 other teams, not just single practitioners, but teams of people at Children's and in the community. And everybody did their one little thing. This person would get an x-ray. That person would do a blood test. This other person would do some kind of an evaluation. And it was really just a mess. And so what we had to do our drug study was we had to run all these children through a rapid sequence evaluation looking for treatable causes of pain. And as they like to say on Quirks and Quirks, lo and behold, 10 of the kids, we improved, they got better. And we never put them into the drug trial. That really made us think that what we needed in the world was kind of a rapid sequence, efficient, targeted way of evaluating this kind of pain. And I'll tell you the other magic sauce there is that we did have a nurse who was part of the study. And so the families, while we were doing this evaluation, they could reach out to this nurse, and she happened to be an ICU nurse, and so she was available all times, day and night. And the families reported how absolutely beneficial that contact was. And it always made us wonder, maybe it wasn't our fantastic rapid sequence workup, maybe there was some magic sauce in this nursing connection. So that's another area of inquiry, like what actually helped make these kids better? Why do we call it pain and irritability of unknown origin? It's because we see pain-like behavior. So we see crying with tears, we see wrinkled, grimaces and foreheads, we see loud vocalizations, we see uncomfortable postures. But as I always remind people, you can see the same thing in a grocery store with a 2-year-old. And that kid's not in pain, he's irritable or she's irritable and she's having a tantrum.
Right.
And so the pain-like behavior that you see doesn't say this is actually pain due to injury.
Yeah.
So we said, well, it's pain and irritability. And if you remember that these children who have neurological differences have abnormal neuronal connections, and they can build up pathways. And that expression of the pain-like behavior, is this child irritable? Are they wet? They just need their diaper changed, which is not pain, it's just uncomfortable. Are they mad as hell at something? Or are they really having a pain experience that's something that there's an injury-like event happening? And that's why we call it pain and irritability of unknown origin, because you say, I'm not sure it's the hips. I don't know. I didn't know there was a dental abscess. I didn't know it was a chronic ear infection, whatever. So the first step along this way is to evaluate the children. So we think of pain as having four, I call it classifications. And one is nociception. So you're in the kitchen, you grab a hot pan, and ouch, it hurts and it stings. And it's in seconds. You feel that nerve. The A delta and C fibers fire, and they say, Rachel, get your hand off that stove.
Yikes.
Yikes. And 60 seconds later, somewhere between 30 and 60 seconds later, the nerve signaling is still happening, but now what's happening is something called the inflammatory soup. There's been tissue disruption, and now all kinds of cytokines are being released. So things that are called interleukins and cytokines are flooding your finger, and that releases all kinds of other proteins and calls in white cells, changes capillary connections, and so we get swelling and redness and tenderness. That inflammatory soup also feeds back onto the nociceptors so that they fire more vigorously. So you've got this nice feedback loop of keep your damn hand off that stove, I'm hot and red, and don't use your finger for a couple of days while it heals. And that's very, very beneficial. If you go back millions of years in evolution, it really is protective. So we call that nociceptive inflammatory pain. You can have inflammation without nociceptive etiologies because we have rheumatoid arthritis, we have other inflammatory conditions. If you have a nociceptive injury, mechanical tissue disruption, acid base, or heat and cold disturbances, you start with the nerve and you get the rest of it. But most of those things we can treat. We can say, wow, the hips are dislocated, or wow, the wheelchair is not working or seating well, or wow, the formula is making their stomach upset. So these are things that we can then address. So if you can eliminate those through a rapid sequence that's logical and not trial and error, but kind of targeted, now you've eliminated a big source of pain. And you say to people, whatever this is, it's not due to this kind of injury. There's no hot stove here. So what are we left with? I said there's four classes of pain. Well, the other one's neuropathic, direct injury to a nerve. We see that in industrial accidents where there's crush injuries and the nerve itself is disrupted. We also see it in things like shingles where the zoster virus reoccurs in older adults, but that's happening in the nerve. It's really classic characteristic. Everybody will say it's electrical, it's shooting, it's buzzing. Unfortunately, these kids can't tell us much about it. So what we kind of rely on is we think the things that usually cause standard peripheral neuropathic pain are not common in this population of kids. I'm going to acknowledge that it's not well understood, but that's about where we're at.
Except maybe an oncology
diagnosis. In oncology, those people are verbal.
Exactly.
And they'll say, wow, I've got electrical shooting and you gave me a big Christine and my foot feels like it's on fire.
Exactly.
So that's pretty straightforward. So again, once you move into the typical developing child or communicative child, you get a lot of hints.
For sure.
So the last part of this thing is a new term since 2017. It's called nosoplastic. And it really is, nosa means nerves, plastic means malleable. And it means that the brain itself has changed because of exposure to pain. And that term was developed because of all the millions of adults who have things like chronic fatigue syndrome and myalgic encephalitis and other things where we know that there's no complex regional pain syndromes, where we know that there's no ongoing actual injury, but the brain seems to be sending pain signals out.
Right.
So once I don't have a nosoplastometer, so I have to do everything I can to eliminate nociceptive inflammatory. And once I've ruled them out, I say what's left behind is likely to be nosoplastic. And maybe the baby's or child is highly irritable in situations that they shouldn't be, or maybe they're having a pain experience. But let's treat that now. So that in a nutshell is where PIUO started and went. What we did is we did a 4-city randomized trial. Children were either randomized to get the intervention right away or to have a 10-week wait period, so that's the control. And then to see, did the immediate intervention identify more kids with nociceptive pain, or did it not make a difference? And then we want to ask questions like, which one of the tests were the most beneficial? Because we think that a lot of the tests that are in the literature just seem to be not of any great benefit, so we want to pare this down. And we also wanted to get some hint about, did these kids just get better by being on a study? That's that kind of question about the nurse's role.
Right.
So we're looking at the data right now, and in some ways the data is a little bit disappointing in that we didn't see a difference between the two groups in terms of pain reduction, which really wasn't our primary endpoint. But when we said, was pain better in the group that was on the study versus the controls, and by the way, all the control kids crossed over and did get the intervention.
Right.
It turned out to be, at least our very first look at the data, is it didn't make a difference. Where I want to go next is, however, parents reported great satisfaction with the study. They said that things seemed to be better. And that implies that we have more kids who we identified particular causes of pain. So we're looking at that data right now. And for the next study, we're also looking at the nurse's role because we're replicating the study only in BC as a rollout of knowledge mobilization to take the pathway and put it out of the hands of 4 expert clinicians. And I was not one of them. I was the study investigator along with Tim, and many others. But we gave it to people who are palliative and complex care experts around the country, and they were the people who actually ran the study. Now we're taking it to general pediatricians who see complex kids in their practices, and we're asking the question, can you implement this in a pretty standard office? Can you do it efficiently? Take it away from the tertiary quaternary center. And we're actually going to study the nursing interaction. So we've got Carolyn Saunders, who's a nurse at UNBC, and she's very interested, along with Sharon Howe, who's our postdoc fellow, at looking, what is the nurse doing and what is the value add of that?
Yeah, so that's great.
That's where the study is now.
Yep.
People worry, like they say, why haven't you published the protocol yet? Well, we're going to publish the protocol very soon once we finish the stats analysis. And I've been reluctant to do it because just because I'm doing a study doesn't mean it's the right protocol.
Right.
So we're in the thick of working with our statisticians to look at this data. I will also add that COVID did not help at all. Sick Kids, which was one of the recruiting sites, the clinics were completely closed to research. CHIO had a very hard time recruiting, but Calgary did. Everybody really got hit hard by COVID in all of the studies, amongst many other ways that people got hit hard by COVID. So that kind of cut our numbers way back and probably made the study more challenging. And that may be one of the reasons we weren't able to show the differences we were initially looking.
So do you have a sense of broad percentages of how many like nociceptive sources of pain?
About 30%.
Okay.
That's our number, is that seem to be coming up. But we have to go back and look at the data. I guess what I really want to know is, well, which of the particular studies? Was it the ultrasound? Was it the urinalysis? What? And the blood work, people order like gallons of blood work, and you're like, really? Somebody's potassium's off and it causes pain? I haven't seen that one yet. So we're trying to get the blood work down to like what's really valuable. And maybe it's a lipase or an amylase. Maybe there's something about bone pain and you can pick up something, or the GGT tells you something about the liver. But there's really, I think we order way too much blood without thinking about what is it going to show us.
Yeah. What are we going to do with this
What am I going to do with like the platelets?
Right. In a pain study. Yeah. So then are you able to share what was the intervention, or no?
I am and I'm not. The thing is that we never got to that med trial because from 10 years, 15 years ago, at the time we were going to look at methadone.
Right.
That was our medicine that was going to be a part of the study. Today we're doing a separate study on gabapentin. Gabapentin has not been well studied in children until very recently. In fact, you could even argue recently with what's called the RAPID trial. They've all been case series. And in fact, at one point, the total number of kids, and this is just in the last few years, described in those case studies was 32 kids. Or maybe it was 34. It was 34 and 32 of them were described by one author. So there's been 2 studies since then that have increased it. One was done in Virginia. One's the RAPID study, which is international. That kind of were just massive scoops of anecdotal data, created these big case series that says, yeah, gabapentin seems to have some benefit in children with these unusual pain conditions. The problem is that it still doesn't tell you really the dose, really the effectiveness, really the efficacy. So we're running what's called an N of 1 study, where each child comes in, gets randomized, double-blinded. The parents and the team don't know whether they're on gabapentin, the active drug, or the placebo, and they will be randomly assigned in order to one or the other. Our third child is just completing that sequence. Unfortunately, we've not been able to recruit that well in that study, and I think it's partly because parents just want to go on the drug.
Yeah.
Or clinicians just throw the drug at them.
Yep.
And then they're on gabapentin for a year or two, and then somebody says, well, is it doing any good? Unfortunately, gabapentin doesn't have a lot of side effects, so it's like, okay, but really? It's one more med. So we're trying to do this. The first child, clearly, the parents thought that they benefited from gabapentin, even though the data didn't show it. The second was very clear that the child was actually doing better pain-wise on placebo, and the parents gladly dropped the drug. And as I said, the third should just be wrapping up now.
Okay.
So, and the parents get their data. They get their personalized data about their child. And so they're the ones who get to make the decision about staying on it off.
Because I feel like gabapentin is one of those generic go-tos if we think that there's irritability or pain that
Right.
we don't know how else to treat it, is that we just go to GABA.
We do, and we do that for a very good reason, which is that clinicians and parents are real. Like, I don't blame them.
Yeah.
Like, everyone's super frustrated. You have this child, and you just feel as a clinician, like, God, I got to do something. Well, here's this simple, not very expensive drug, and I'll give it to them. And so I'm not critical. I just wish people would send more people into our N-of-1 study so we could say, well, actually, it works for this many kids, because I know it works for some kids. And it's a 40% chance or an 80% chance it'll work. And to say, and your ideal dose is this.
Yeah.
When you get to X mgs per kg, you will be using the right dose. And if it's not working, stop. And if it's working, carry on.
So one of the things that I personally have found very helpful is this sort of draft of a protocol in your study, the PIUO study, as I've been consulting with pediatricians of this child's super irritable. We've tried this, we've tried that. Nothing seems to be working. What's next? And I've been able to look at your draft that you shared with me, which is fantastic, of have we looked at all of these things?
Right.
And I can get a pediatrician to say, oh, that's excellent. I would be happy to follow up on blood work, ultrasound,
Right.
urine tests, etc.
Right.
We rule things out, and then we say, okay, maybe now we try gabapentin, clonidine, SNRI, whatever it is that we're going to do next for this
Yeah.
sort of central neuropathic pain
Yeah.
that we're seeing. So I can imagine that this could be extremely helpful for the community pediatricians in the future as a way to say, hey, palliative care team, I've done all of this. This was ruled out. Help. I need your
Thank you.
expertise now.
And I think in addition, I'm going to say that the parents are going to benefit because the parents who are not physiologists, they're not neurophysiologists, they're going to have an understanding that my kid is in pain. Doctor, nurse, you just haven't found it. What's wrong with you? Whereas if we can come back and say, yep, there's pain and it's brain-based pain,
Yep.
or it's nervous system-based pain. I prefer brain-based pain, and he's not making it up.
Yes.
You know, it's brain-based pain, and here's the approaches we use to it.
Yeah.
And people are like saying, well, gabapentin, blah, blah. We are just at the tip of the iceberg to try to think about what's the best way to modulate this.
Yeah.
We throw a lot of ideas around about neurotransmitters and what to do, but we're really just at the beginning. Now, where else is this important in the world? It's important because geriatrics has the exact same problem with dementia patients. And geriatricians and pediatricians have a lot more in common today than they did probably 40 years ago.
Yeah.
And so geriatricians see this problem. The other group, when you go on the Pete's Pain listserv, the other very active group are veterinary anesthesiologists. Animals have this problem, and they don't say, Fido doesn't point to her, left hip. I mean,
Yes.
we can figure it out. So there's really a huge swath of people out there with, and again, when we go back to the origins of the term nociplastic, there's people who keep saying, I have pain, I have pain, I have pain, and doctors who rightfully, wrongly don't believe them.
Yeah.
Because they're stuck in this, like, well, it's got to be peripheral nociceptive. We've known about nociplastic pain for a while.
Yeah.
We didn't have good terms for it. We used to call it central neuropathic and other weird functional pain. But it's got to move out of the shadows of being pejorative.
Yeah.
I will add one last plug here.
Mm-hmm.
I think there's great advantage to being what I call a clinician scientist when you can see a patient, come up with a question, translate that into a project, take the results of your project, translate that back into bedside care. And this is my plug for funding clinician scientists at all levels and in all disciplines who can carry out projects, or for people to partner with clinician scientists, because it's the fastest way we mobilize knowledge.
Yeah, and I can see the direct impact that this research has on our clinical practice at Canuck Place. So I can absolutely appreciate that some of these projects have a direct correlation to the work that we're doing. So.
Absolutely. And I think the other thing for any listeners to this particular episode who are not pediatric practitioners, the average length of time that we know kids on this program is 6 years. I think it's a very long time. It's not a few weeks that you might see in adult palliative care.
Yep.
And so along the way, we become responsible for a whole bunch of problems like their pain of unknown origin that you might not necessarily deal with in other contexts if it was clear short-term end-of-life care.
Yep.
These kids have they have a best before date, but we don't know what it is. So we just carry on with them until things do change with them eventually.
And I can also see that a lot of our population are aging longer than 20 years ago.
Oh, absolutely.
And as they enter into the adult world, there's a lot of adult providers also that don't know how to manage some of these complex conditions. Adults who are nonverbal and can't explain their symptoms are also really difficult to manage. So eventually, this is also going to guide that young adult population that graduate off our program and end up in adult services as well.
Yeah, and I hope that there are people in the adult world, whether it's in palliative or family practice or even internal medicine, who will take this population on and start taking them seriously and providing care and not letting it be part of just a fragmented organ-based care system. Yeah.
Well, thank you very much
Thanks,
for
Rachel.
taking the
It's fun.
time. It was great to talk to you.
Yeah.
And I look forward to what's next.
Yeah, I'll let you know.
Thank
Okay,
you.
thanks.
Thank you for listening to this episode of the Sunflower Palliative Care Podcast. These podcasts grew from a seed of an idea as we talked with our colleagues in the Sunflower Children's Network. The Sunflower Children's Network is an initiative of Two Worlds Cancer Collaboration, which focuses on children's palliative care. We hope to build a world where no child suffers from serious health-related issues. To learn more or to donate, please visit twoworldscancer.ca.